Hello, everybody. Thank you for joining JOMA's Women's Health Committee webinar on PCOS. My name is Tamar Itzkowitz, and I'm on the executive board of the JOMA Women's Health Committee. The Jewish Orthodox Women's Medical Association, also known as JOMA, is a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our department, the Women's Health Committee, was created with the goal of increasing access to women's health education to the Orthodox community, thereby empowering women to be better equipped as self-advocates. We believe it's important to know about our bodies, know what to expect when we see our doctors, and know which questions to ask them. If you haven't done so already, please take a minute or two to fill out the pre-webinar survey. You can find the link to that survey in the chat, and a QR code is also currently being screen shared, which you can use to access that as well. There will also be a post-webinar survey, which you will receive after the webinar. Please try to fill out both surveys, as this will help us conduct further research on this type of education. By filling out both surveys, you can also be entered into a raffle to win a $50 Amazon gift card. Tonight, we will be covering PCOS. We will be addressing the following topics: what PCOS is, diagnostic criteria, what to ask your doctor about, why it's important to get a period, and treatments. We will also discuss infertility, the dermatological consequences, endocrinological consequences, and of course, the psychological consequences of PCOS. We'd also like to remind you that this forum is not a substitute for getting individualized medical advice from your doctor. There will be a Q&A at the end of this event, but please keep your questions broad. All questions should be posted in the question box. If you would like your question to remain anonymous, please hit the Remain Anonymous button when submitting your question. Your presence on this webinar is completely anonymous. Your video and voice are not enabled and you cannot be viewed. Your presence here is totally anonymous. Our first speaker today is Dr. Maslow from Extend Fertility. Extend is actually sponsoring this event, so thank you. We're gonna hear from her first. So Dr. Maslow attended the Albert Einstein College of Medicine, where she received an MD with distinction and was inducted into the Alpha Omega Alpha Medical Honor Society. She completed a residency in obstetrics and gynecology at the University of Pennsylvania and subspecialty training in reproductive endocrinology and infertility at the University of Connecticut, where she also completed a master's degree in clinical and translational research. She is a reproductive endocrinologist and the director of research at Extend Fertility and Premium Health Center. She serves as the director of medical education for the North American Yoatzos Halakha program and sits on the founding board of directors of the Jewish Orthodox Women's Medical Association. Dr. Maslow, you have the floor.
Hi, thank you so much, Tamar, for the introduction. Welcome, everyone. This is really one of our hallmark events, and we're excited to see so many of you here with us. I'm going to share my screen if you give me 1 second. Okay. So in the short period of time that I have the task of running through some of the basics of polycystic ovarian syndrome and some of the effects that it has on our reproductive health and some of the treatment options that are available. So we have a lot to cover in a short period of time. And so bear with me. Other than the fact that I obviously work for Extend Fertility and they are the ones who are generously sponsoring tonight's event, I don't have any additional disclosures. So what are some objectives? We're going to try and touch upon today what is PCOS and what it is not. We're going to spend a fair amount of time discussing the diagnostic criteria, and not because I want to bore you with a medical lecture, but because I think it's really important. And so many times the diagnosis of PCOS is sort of thrown around without really regard for the technical criteria. We're going to talk about the reproductive concerns for women with PCOS, some of the treatment options for women with PCOS, and some of the long-term reproductive outcomes. And then I will pass the baton over to my esteemed colleagues who will touch upon some of the other issues as well. So some fast facts about PCOS. It is one of the most common endocrine disorders of young adults. It's estimated that somewhere close to 1 out of every 10 women in the United States may have PCOS. There's also a lot of different facets, many of which you'll hear about tonight. There's reproductive aspects, there's metabolic aspects, there's dermatologic aspects, and there are some women who can have all of these symptoms or only a few. And there's really a wide range in the way that this syndrome is represented. There are also strict diagnostic criteria. So even though there's really a wide range in the way women may present, there's really a very strict way in which to identify which women are affected by PCOS. Oh, hold on. There we go. So we're also going to do a little bit of myth busting. First of all, and these are a lot of my pet peeves. So one thing is that it's not actually cysts, and we'll talk about that. But when you hear about your friend who had a ruptured ovarian cyst, women with polycystic ovarian syndrome don't actually have lots of cysts in that term. We actually call it cysts, but in true form, it's actually something called a follicle, which we'll discuss what that is and why it's different than a cyst. Women with PCOS actually end up having similar family sizes to those without PCOS. So while we think of PCOS as an infertility diagnosis, in the end, women with PCOS tend to overcome their infertility in a variety of ways, and we'll discuss it. PCOS is often associated with women being larger size, being overweight or obese, but you can also have PCOS and be thin. Similarly, not all larger size women, and not all larger size women who have menstrual disorders have PCOS. So we'll think about that as well. The other kind of cool fact is that you actually can grow out of PCOS, or at least some of the reproductive aspects of PCOS. So how do we diagnose PCOS? For many years, there weren't very clear diagnostic criteria. And so in 2003, a group of well-regarded European reproductive endocrinologists got together in Rotterdam to set up some useful diagnostic criteria that could be utilized across the board, so that if one person diagnosed a patient with PCOS, another doctor in another country could understand what that meant. So they said you had to have 2 out of the 3 characteristics. One is what we call oligo or anovulation, so irregular cycles that are lasting a very long time. Many people will say that you go more than 90 days without a cycle. Okay, that's a lot. Hyperandrogenism, which means high levels of androgens. Androgens are classically what we call quote unquote male hormones, although women normally have androgens, but women with PCOS tend to have elevated androgens, and that diagnosis could be made clinically, meaning they had signs of elevated androgen like male patterned baldness or excess hair growth, or high levels of these androgens on laboratory values, and polycystic appearing ovaries on ultrasound. Right? And this is where the name sort of comes into play. And what I've put for you here are pictures of ultrasound images of ovaries. The one on the left is what we would call polycystic appearing. It has lots of these little black circles. Those are called follicles. Follicles are small little fluid-filled bubbles that contain immature eggs. And women with PCOS, and one of the underlying features of PCOS is that women have lots and lots of eggs available. And so they have lots and lots of follicles. And so you see this, what we call polycystic appearance to the ovary. I like to tell people, and by now I feel like a lot of people have heard me say this, and I say it on Instagram also, that polycystic ovary, or even non-polycystic ovary, tends to look like a chocolate chip cookie. And what we see are these little chocolate chips, and women with PCOS tend to have lots more of them. This one here in the center is a more typical ovary with, plenty of follicles, but not quite as many. This one on the right here is an ovarian cyst. Now, these are all very similar size, so you can see the difference. An ovarian cyst is a large cyst, a large collection of fluid. It's typically, it may have been a follicle that never ovulated. It may have been, there's a variety of different types of cysts. They tend to not be hormonally active. And sometimes they can rupture, and that can cause a lot of pain and discomfort. And so that's when you hear people say, oh, I had an ovarian cyst that ruptured, or it needed to be surgically removed. Those are very, very, very different than someone who has PCOS. It's very important to kind of, those two things are really not the same, and it's really unfortunate that they kind of share the same name. The last important thing is that before you can truly diagnose someone with PCOS, you need to exclude other causes of these types of symptoms. The most important for this discussion might be CAH, or congenital adrenal hyperplasia, which is a genetic disorder that can mimic PCOS in many ways, and is actually exceedingly common in the Ashkenazi Jewish population. So I actually diagnosed CAH relatively frequently with women who come to me thinking that they have PCOS. So it's something that needs to be excluded before you can truly diagnose PCOS. Now, these are the more updated guidelines. These were started in 2018. And one of the reasons they had to update the guidelines is because adolescents or young adults were being diagnosed with PCOS at tremendous numbers. And many of these women really didn't fit into the true feeling or the true meaning of PCOS. And so what we were ending up seeing is a lot of women who were being told as adolescents or young adults that they had PCOS. They went on birth control pills. They assumed that there was something wrong with them. And then, they get into adulthood only to find out that that was never really the case. And so the criteria were adopted in order to recognize that adolescents really need to be in their own group. The other piece is that ultrasounds have gotten so much better since 2003. And so we can see a lot more, and we can see a lot more follicles. And so we have to be a little bit more discerning by saying that using the ultrasound criteria as a diagnosis. So for adolescents, you really have to have both features of the irregular cycles and the elevated androgens. And it's not recommended to use ultrasounds because in women are born with all the eggs we'll ever have. Young women have lots of eggs. It's normal to have quote unquote polycystic appearing ovaries in adolescents and young adults. These guidelines, again, highlight that for adolescents, if you're going to say to a teenager or to a young adult, and here the adolescents can go into the early 20s, if you're going to call them hyperandrogenism, you need to have severe clinical features or significant laboratory values. And anovulation, remember, irregular cycles is a key feature here. So if you're going to diagnose an adolescent or a young adult with PCOS, they have to have irregular cycles. But there's a caveat here for young adults, because what we've learned is actually it's normal for women and young adults to have irregular cycles, even up to many years, for several years after their first period. So menarche here means the first period. It's totally normal to skip many periods that first year after menarche. So we really can't go diagnose a 13-year-old with PCOS. In that time period from 1 to 3 years, you really can't call it anovulation or irregular periods unless they're going greater than 45 days, right? And, 3 years onward, we have this, between greater than 35 days or less than 8 cycles per year. But it's so common for adolescents and young adults to have irregular cycles that it's not really fair to pathologize it, to say that it's something abnormal. Because many of these girls and young women are in their mid-20s will start having regular cycles, and they don't actually have PCOS. They may have what we call ovulatory dysfunction, meaning they're not ovulating regularly. And sometimes there are 21 and 22-year-olds who are trying to get pregnant, and they may fall into a category that, might describe the infertility components of PCOS, but they may not actually truly have PCOS. Okay, we talked a little bit about the term polycystic ovaries on ultrasound. Like I said, with 8 years post-menarche, right? So think about women, most girls are going to get their period at 12 or 13. That means till 20, 21, 22, you cannot count these ultrasound pictures as part of the diagnostic criteria for polycystic ovarian syndrome because it's normal. They've increased the number of follicles that you would consider abnormal from 10 to 20, partially because the ultrasounds are so much better now. We see them and they're not actually abnormal. So a lot has changed, but a lot has stayed the same. So what's really happening? Why is it that women with PCOS are having this disruption in their cycles, since the cycles is really kind of the hallmark feature of the reproductive aspects of PCOS? Women with PCOS have a very high abundance of egg supply. Like I said, women are born with all the eggs we'll ever have. And eventually we run out when we go into menopause. There are some women who start losing their cycles because they're running out of their eggs too soon. And that's a completely different phenomenon and much harder and more challenging to deal with. But women with PCOS have a really, really high egg supply, and the communication between the brain and the ovary. And I purposely brought this very complex image because I want people to recognize it's a very complex, delicate communication between the brain and the ovary that tells the ovary to select a single egg to grow. But what happens is that there's so many eggs present that often you don't get a single egg that sort of pushes forward and drives the menstrual cycle. So you get a lot of these starts and stops. So women with PCOS tend to have slightly elevated estrogen levels because their eggs are kind of starting to produce estrogen, starting to go through the cycle, but they don't actually get all the way through. So they get stuck kind of in this early phase of the menstrual cycle. And it's as if they're in like that first week of a typical 28-day menstrual cycle for months at a time. They get stuck. But they do ultimately at some point recruit eggs or an egg and ovulate, and they can. So they get, many women do get some periods over the course of the year, but it's very unpredictable. So somebody who's trying to conceive, for example, it's really difficult to know when to have appropriately timed intercourse if, you could have 90 days between your ovulations. So what are some of the reproductive concerns that happen as a result of PCOS? So the first is long-standing irregular cycles, particularly with PCOS, meaning you go these months at a time without getting a cycle, without getting a period. You're exposing the lining of the uterus to what we call unopposed estrogen, meaning there's estrogen available because the ovaries are starting to produce a little bit of estrogen, but then they never really complete the cycle, and there's no progesterone that comes after ovulation. And this long-standing unopposed estrogen can, over time, increase the risk of uterine cancer. So that's a big concern, and that's really why you often hear that women with PCOS, we try to make them have at least 3 periods a year. That gives you the opportunity to shed the lining of the uterus. There are other ways to protect against the risk of uterine cancer, but that's kind of the typical one you hear. Unpredictable or absent ovulation makes it really difficult to get pregnant. Now, notice I didn't write infertility here. I wrote subfertility because women with PCOS are often actually what we call hyperfertile, meaning they have tons and tons of eggs. And if you were to open the floodgates, you'd have lots and lots of available eggs, but it's this communication between the brain and the ovary that breaks down. And if we can enhance that communication between the brain and the ovary, there actually isn't technically a deficiency in the fertility itself. So what are some of the treatments? First, just to think about the irregular cycle. So again, the most important thing is to protect against the long-term risk of uterine cancer. The way to do that is to oppose the estrogen with progesterone. You can do this in a variety of ways. The easiest is birth control pills. So we hear lots of people talk about how their doctors are putting them on birth control pills because they have PCOS. Birth control pills do a lot of things. One, so it opposes the estrogen with progesterone that protects the lining of the uterus. It can make cycles very predictable because it's going based on the pills, not on this kind of random association, communication between the brain and the ovary. It also decreases a lot of the circulating hormones. So some of the other aspects that we're going to hear about from my colleagues, Dr. Krausz and Dr. Polotsky, can be improved with birth control pills. You can do progesterone withdrawal. So some women, like I said, would like to just get 3 periods a year. So we give them, 10 days of progesterone. A week after they'll bleed, that sheds the lining of the uterus. And that kind of is, checks the box for 1 period a year. You can also have the levonorgestrel IUD or the Mirena, there's a whole bunch of them now, Liletta, Skyla. But the progesterone in that IUD will oppose the estrogen and protect the lining of the uterus, even though those women often don't get periods at all. So that's like a little bit of a different approach, but it's just as effective. How do we treat infertility or subfertility? How do we help women with PCOS? Or the truth is, women with ovulatory dysfunction, how do we help them get pregnant? And this is really how most of the time I start seeing women who have PCOS is they come to me because they're trying to conceive. And for many women, that's where they first get their diagnosis because they're trying to conceive and either they were on birth control pills or they weren't, but they didn't realize how irregular their cycles are. And now finally they're trying to get pregnant and their cycles are so out of whack and it's really hard to know. Now I will say this, if your cycles are out of are irregular, meaning you're going more than 40 or 35 or 40 or 50 days without a cycle, you do not need to wait the recommended 12 months of trying before coming to seek assistance. Another one of my pet peeves is seeing a couple who, comes to me for fertility treatment or assessment, says they've been trying for a year, and I say, oh, when was your last period? Oh, I haven't had a period in 13 months. So you haven't actually been trying for a year, because each period comes after an ovulation. And if you haven't ovulated in 13 months, then you haven't even had an opportunity to get pregnant over the last 13 months. And so the hallmark approach of treating those who are trying to get pregnant is ovulation induction, trying to induce ovulation. Now, how can we do this? Dr. Polotsky, I'm sure we'll talk about some of the metabolic aspects. There were big studies that were done several years ago looking at whether you could adjust some of the metabolic symptoms of PCOS, and would that lead to ovulation? So I'm going to skip the first one for a second and go to glucose sensitizing, right? So lots of people get put on a medication called metformin for PCOS. Metformin is started as a medication for diabetes. It decreases circulating glucose. Women with PCOS often have trouble, or some can have trouble with their insulin and glucose. And so the thought was, if we give metformin, that will decrease, it will sensitize the body to glucose, and that will help alleviate some of these symptoms and lead to ovulation. Now, what I'm showing you here is a study that was done, a big study that was done and it was published in the New England Journal in 2007. And what it shows is that metformin, which is this medication that's still extraordinarily common for women with PCOS, is actually really not that effective. And so I see patients who see me all the time who are like, well, I got put on metformin and nothing happened. And I say, okay, I'm not that surprised. It really doesn't work that well. It does work for some women, but not that well. So you can see that the pregnancy rate was 7.2% with metformin alone. So there really isn't a huge benefit to metformin, particularly in women who have normal glucose parameters. And yet it is something that's often used. Nowadays, there's also a lot of over-the-counter use of inositol or myo-inositol. Similar, the studies really don't support that it's better, and it's probably worse than kind of our classic medications that we use to help induce ovulation. Now I'm going to touch upon weight loss for a moment, because that's a big hot button topic that comes up a lot. There's a lot to talk about, and we could probably have an entire discussion about the role of weight loss and whether it's appropriate to recommend weight loss to patients or whether it's not. And this is, I'll give you my take, and with the caveat that it's my personal take and how I treat my patients, and I'm not necessarily speaking on behalf of the medical community as a whole. But by the time I see patients who come to my office for fertility treatment, if the woman is overweight, she knows she's overweight. She's already tried, I'm certain, many routes to lose weight. I know that my patients, when they come to see me, the last thing they want to do is see me. If there was something they could do to have avoided having to come see me, they would have done it. And I know that they've tried. And so, telling my patients, recommending that they should go try to lose weight before getting treatment, in my mind, is really not effective. It's not actually treating the patient with what she needs. And so I share the data, and I share the recognition that pregnancy rates are higher when women are able to lose weight, but at what expense? And the truth is that very few women are really able to achieve that kind of weight loss. It's just not realistic. And some of the mechanisms by which women try to achieve the weight loss is not healthy. And so I want my patients to go into their pregnancies as healthy as possible. And if that includes a healthy amount of weight loss in a healthy manner, great. And if that's not an achievable goal, then we move on to the next thing. And that's where my philosophy is. I'm going to move to point number 3, which is discussing Clomid and letrozole. So Clomid and letrozole are our classic go-to ovulation induction agents. Clomid has been around for decades. It strengthens the communication between the brain and the ovary and helps push the ovary to select a single egg to grow, to kind of drive ovulation forward. In 2014, there was another big study that was done that compared Clomid to letrozole, which was another medication. It works similarly to Clomid. And what they found was that it had slightly higher live birth rates in women with PCOS. In women who did not ovulate regularly, the letrozole did a better job. Now, when I treat women, Orthodox women, I often don't use letrozole as my first line because the one thing that letrozole does is cause staining. Reasonably commonly. And so I have women who, if you are observing the laws of Nida and you take letrozole and then it causes you to bleed and now you've delayed the mikvah, I could make you ovulate, but if I made you ovulate before the mikvah, then I haven't actually accomplished anything. And so often I'll still use Clomid as my first line treatment. But I do find that letrozole is very helpful and I still use it very frequently. And sometimes we can work it out with the staining, but they're both really great medications. Years ago, there was a concern that letrozole could be associated with birth defects. There was a black box warning. We're going back many years. It was based on a very small study in an Australian hospital that was really a very flawed study. And doctors had been using letrozole forever and didn't find that there was a higher rate of birth defects. But they did a long-term follow-up study of the babies born from this study and found no significant difference between Clomid or letrozole. And that kind of put the whole thing to bed. And nowadays that doesn't really come up anymore. And I'm really not at all concerned. I have zero hesitation to prescribe letrozole. To friends and, patients, and I have zero hesitation.
There's a 4-minute warning.
Thanks. This next way we treat the fertility for women with PCOS is with injectable gonadotropin. So sometimes, really, really brittle PCOS, no matter how strong you enhance the communication between the brain and the ovary, it's just not enough. And when that happens, really our only choice is to directly stimulate the ovary. And we do that with injecting recombinant or synthetic versions of the hormone that the brain uses, but in higher amounts. Now, when we do that, there's no brain involved. So there's no regulation other than what we as the physicians do. And so classically, using just these gonadotropin, these injectables, led to a very high rate of multiples because it can recruit more than one follicle to grow. And actually, many of the kind of famous stories or TV shows of families that had high order multiples were not from IVF, but were actually from injectable medications that were not monitored and adjusted appropriately. In my practice, and one of the things we see a lot of young women with PCOS. I see a lot of young women in the Orthodox community with PCOS or with ovulation induction that's maybe not yet PCOS or can't be diagnosed as PCOS yet. And we often are more comfortable using gonadotropins than other practices might be. We do a high amount of monitoring. We have these women come in for evaluations like almost every day, and we cancel the cycles when we think that they're going to be at too high a risk of multiples. But often when there is this risk, or if it doesn't work, the next step becomes IVF. And there are many places that view IVF as a safer option than injectables because it doesn't come with this potential risk of multiples or even high order multiples. What we know is that IVF has become so successful that a single embryo is the best option and gives you the best opportunity for a healthy pregnancy. Multiples and having, certainly we see lots of twins. Twins are great. But they do come at a higher cost, and those pregnancies are more complicated. They're at higher risk. There are risks for miscarriage and loss and complications to mom and to babies. And so a healthy baby and a healthy pregnancy is really the ultimate goal. Thanks. So I'm second to last slide. So IVF can in many ways be a safer option, particularly for women who want to have a large family. IVF also is an investment for the future because you can use it as a form of fertility preservation, meaning you could make, especially in women with PCOS, because they have so many eggs, they're going to have a very high retrieval rate. They're going to have hopefully a lot of embryos to save for the future. And so you can, in theory, make like an entire family out of one shot. And women with PCOS classically have the highest rates of success with IVF. Now, egg freezing, generally for single women, many women ask me, can I freeze my eggs with PCOS? And the truth is that egg freezing with PCOS is like the best combination. And at Extend, again, a little plug for Extend, we started as a practice that focused a lot on egg freezing. And this comes up very frequently. And women who have PCOS will end up freezing large numbers of eggs because they have so many available, but they also have a higher chance of needing those frozen eggs because they may experience infertility in the future. So it can be a very smart investment for women with PCOS who are single. What are some of the long-term outcomes? This, I think, is my last slide, so we're wrapping up. One is that regular cycles increase with age. Now, women sometimes find this surprising, that they can, quote unquote, grow out of PCOS. And I actually have a patient who needed, I think, injectable medications to get pregnant with her first few children. And then in her late 30s was like, oh, now I started getting periods again. And I said, you don't need anything, just try to get pregnant. And she didn't believe me that she could get pregnant on her own without needing any treatment. And then ultimately she did and had a baby because as the egg supply decreases naturally, eventually you get into a range in which the brain is able to communicate functionally with the ovaries and the cycles return. Like I mentioned, family size is similar between women with PCOS and those without. And some of that might be because women with PCOS get treatment and the treatment is relatively successful. And so overall, women with PCOS don't end up necessarily being hindered from achieving their reproductive goals. 60 to 80% of women with PCOS will conceive spontaneously at least once. It means most of these women are going to get pregnant at some point in their life without needing any assistance, right? It's just super difficult to predict. And so I tell patients that they're often very incredulous, but it's true. IVF and egg freezing success rates are higher for women with PCOS. We've mentioned that. And menopause tends to start later for women with PCOS than non-PCOS women because they have so many eggs, like I said, and that trajectory of decline, it just takes them longer to run out of eggs. So I'm going to end here and then I'll be available to answer questions at the end.
Okay, thank you so much, Dr. Maslow. That was great.
You're welcome.
Our next speaker is Dr. Polotsky. Originally from Belarus, Dr. Polotsky graduated from New York University with a bachelor's in biochemistry and received her medical degree from Albert Einstein College of Medicine in 1999. After completing her residency in internal medicine at Montefiore Medical Center, she spent the next 6 years working in the general internal medicine practice, teaching residents and medical students. A significant part of her practice in the Bronx, New York, was dedicated to the management of diabetes and metabolic disease. She completed an endocrinology fellowship at the New York Hospital, Cornell, and Memorial Sloan Kettering Cancer Center in 2010. She is board certified in both internal medicine and endocrinology and practices at Kaiser Permanente East Denver practice. Dr. Polotsky, you have the floor.
Hi, and it's a pleasure to meet all of you. And it's a little hard for me to go after Bat-Sheva, but I'll try. Thank you for joining us today. I'm going to share my screen. Let's see. Okay, share. Are you able to see my screen?
Yeah.
Perfect. Okay. Sometimes, the technology doesn't always respond. Okay, from the beginning. Excellent. So I have nothing to disclose because I work for Kaiser Permanente, which is an HMO. And our learning objectives is really just to discuss the symptom sequelae of the PCOS, reproductive as well as non-reproductive, and what happens, as you get close to menopause. Just want to ask a few questions, but since you cannot answer me, we're just going to pretend that you have answers. Do women with PCOS are likely to remain childless when they are compared to general population? That's question number one. I think Bat-Sheva actually answered that in her presentation. Irregular menstrual cycles get worse as women with PCOS advance into their 40s. And after menopause, do women with PCOS have a higher chance of having a cardiovascular disease, and should they be aggressively monitored? I'm not going to go through the diagnosis since Bat-Sheva did such a beautiful job with that. Just to basically, the two different types of criteria, and the NIH is based on high androgens and fewer cycles. And in Rotterdam, a little more complicated, where you need to have 2 out of 3 criteria to diagnose PCOS. So what is the natural evolution of the reproductive symptoms in women with the PCOS? So regular cycles, if you look at this specific study and the other studies, show that as you age, regular cycles improve. And with age, your testosterone level or androgens levels actually decrease with age. And this is the study that was done by Winters. And you can see, look at the level of testosterone, you can see that as you get to be more than 47, you slowly, you still have more androgens than normal women without PCOS, but they do improve over time or decrease over time. And as Bat-Sheva mentioned, this study that was published, which was kind of interesting, and it was based on a recall by patients, that there is no difference in family size in patients compared between PCOS and healthy controls, which is, I think, excellent news for women with the PCOS. And they looked at the number of siblings, sisters, brothers, and as you can see by numbers, there was no difference. So 67.5% of PCOS women will become spontaneously pregnant at least once. And among women who tried the pregnancy, 86% of women gave birth to at least one child. And 73% of women do so at least once following spontaneous abortion. Spontaneous conception, sorry. So this is just a study proof of family size and change. And sort of a lot of times I've heard from many of my patients that since I have a PCOS, I'm unlikely to get pregnant, or I need to seek fertility services most of the time. But a lot of times people are able to be pregnant, and over time in their lifetime, they actually do well. So this specifically looks at the success with the in vitro fertilization. And this study looks at the PCOS patients as well as patients with the tubal factors. And PCOS actually does not worsen your chances of in vitro fertilization, versus if you look at the tubal factor, as people age, usually your success of the in vitro fertilization decreases. So that's another set of great news for women with PCOS. So for the reproductive systems we discussed, but family size is similar to general population, which is excellent. An ovulation and menstrual regularity improve with aging, so is decrease in androgens. What is not clear is what happens with the early miscarriage or spontaneous abortion in PCOS. So what happens with the non-reproductive sequelae in the women with the PCOS? So the non-reproductive sequelae, or what happens metabolically, is women with the PCOS has insulin resistance. They have abnormalities with their lipids. So both increase in the bad cholesterol and triglycerides, and decrease in the good cholesterol, HDL, as they compare to the age-matched controls. They have metabolic syndrome, and then we will discuss what is the relationship between smoking and what is the relationship between the PCOS and cardiovascular outcomes. So as far as the insulin sensitivity is, this is looking at the PCOS over time. And as you can see, over time, your waist circumference increases. More or less, your insulin stays the same, but it's higher the insulin sensitivity is, or insulin resistance is more prevalent than PCOS. But this is just looking at what happens over time with all these different metabolic sequelae. And if you look at the red line, that's your testosterone, as I mentioned before, that will improve over time. So one of the biggest studies that look at the metabolic syndrome is this one study of women's health across the nations, and it's actually looked at metabolic syndrome across different races. And what was interesting in this study, first I'll just discuss the study itself. It's the women between 42 to 52, so the perimenopausal to menopausal women. They had the menstruation within the past 3 months, and they couldn't have any hormone therapy. And they had a uterus and at least one ovary present. So this is a distribution. It's a very famous study, one of a kind for the perimenopause, studying women as they're moving into menopause. And they actually had women, including Hispanic women, Japanese, and Chinese, in addition to African Americans and Caucasians. And which was interesting in the study, outside of PCOS, as women transition through the perimenopause, they had a much higher chance of metabolic syndrome. What is interesting is to find out what happened with women with the PCOS. Did they have more metabolic syndrome compared to the women without PCOS? So that's, we'll discuss. But before I get there, just review metabolic syndrome itself. And it's basically increasing abdominal weight, low HDL, which is low good cholesterol, high triglycerides, high blood pressure, and abnormal fasting glucose. So this is the criteria they used as far as defining women with a PCOS in this one study. And as you can see is that if you just had high androgens versus high androgens and also oligomenorrhea, the your frequency of the metabolic syndrome was higher. So just being oligomenorrheic versus high androgens versus having both had a different sort of likelihood. So having both of the higher androgens and fewer cycles was would put you in a higher chance of having a metabolic syndrome. And the study was published by my husband, Alex Polotsky, so I have to give him an attribution. But if you looked over time and compared to women with the PCOS, they did not find a statistically significant increase in metabolic syndrome over time as compared to women without PCOS. Again, another set of good news. So even though you do have a higher sort of metabolic syndrome in the PCOS, as you progress over time through the perimenopause and so on, you did not do worse than women without PCOS. So, which very different from comparing this to weight and smoking. So women who, and again, PCOS did not in itself make things worse as you progress through perimenopause, but your BMI for sure greatly increased the likelihood of or prevalence of metabolic syndrome, and smoking increases by very, very significantly. So I think this is probably one of the crucial things, both in the PCOS women and in women without PCOS, when it comes to metabolic syndrome and transition through the perimenopause, the lower your BMI, and if you don't smoke, you're going to fare better. Again, as the most women will get some degree of worsening of metabolic symptoms and parameters as they get through the perimenopause to menopause. But for PCOS, it's not worse than the rest of the population. So this was another study published by Dr. Legro, and another study in fertility sterility that looked at smokers. And they had 17% of their study population, they were smokers. and smoking did worsen insulin resistance. So just connecting the dots, if you got the patient with the PCOS, they already have a worse insulin resistance, you put smoking on top of this, then you're obviously putting yourself in a much higher risk of having a negative metabolic outcomes. So switching to a different study, I want to spend a few minutes talking about cardiovascular mortality. So surprisingly, you can see here, and sometimes it's hard to read tables of all these scientific studies, but by itself, PCOS did not put patients into a higher cardiovascular mortality risk. So they're not dying more from the heart disease compared to other patients. I mean, if you look here, basically just did not reach statistical significance. So even though the hazard ratio likelihood sort of like having the disease was higher in PCOS, when they adjusted for age, it did not reach statistical significance, so we cannot scientifically say that the mortality is increased in PCOS, even though the numbers show it may be increased, statistically it's not. So as of this kind of moment of time, unless something changed recently, in itself, menstrual irregularity does not increase the risk of dying from the heart disease. And this study was done in Kaiser, and they followed women from 1959 to 2007. So just to summarize is that despite weight gain associated with aging, over time, the insulin resistance does not get worse. It's higher, what we call the prevalence. Like so what is the percentage of percentage of women that have metabolic syndrome or insulin resistance? But as we age, PCOS doesn't seem to get metabolic things worse, which is, as you see in the theme here, your androgens don't get worse over time, and your menstrual irregularity improves over time. So basically, you, as Bat-Sheva said, you basically grow out, almost like you grow out of the PCOS. Prior to menopause, indeed, the high androgens do increase metabolic risk. So your metabolic syndrome prevalence or all of these other parameters do worse in PCOS, but as you progress, it doesn't. And after menopause, they don't develop, women with the PCOS do not develop metabolic syndrome any more rapidly than the women without PCOS.
There's 5 more minutes.
So in the summary, is despite the weight gain associated with the aging, incidence of insulin resistance doesn't appear to get worse over time, even though, as we discussed before, anyway, I think I'm confusing my own slides because it's when you present virtually. I just want to say that I already discussed the first 2 bullets, 3 bullets. It's the last bullet is we really, probably one of the biggest things we can do is to pay attention to the obesity or weight and smoking. And it's actually regardless of the PCOS status, because PCOS itself doesn't seem to aggravate things, especially as you get close to menopause. So I would like to, my last 2 slides is really dive into the weight and PCOS. And we do know that with a significant weight loss, you quite impressively improve clinical outcome for patients with PCOS. And as Bat-Sheva mentioned, we know, though, unfortunately, that most people don't follow through with or they're not as successful to follow through the weight, with the weight and loss and lifestyle changes. So 46% of people will actually not continue with trying to pursue lifestyle changes. Weight gain is higher over time in patients with the PCOS, in spite of multiple studies showing that their motivation is much higher to lose weight. They are gaining weight more than women without PCOS, and as supported by animal studies as well. It is unclear, though, what happens in PCOS, sort of why women gain weight. So it's possible, depending on which study you look at, that high androgens may be driving, and as well insulin resistance may be driving changes in appetite, energy, balance, and metabolism, but it's actually not proven. In one of the studies I looked at, it was very interesting that in the animal models, that high androgen in itself was not necessarily driving the problem with the metabolic rate, but when you introduce poor diet to the animals, then suddenly having high androgens made it impossible for them to basically metabolically balance their weight, and they would gain weight.
There's two more minutes.
Yeah, just one slide left. So a lot of people are looking in composition of your diet. So what are you eating? Is that going to influence the PCOS? And I would say this is a space where I think there's potential, but not enough evidence or proof that it makes a difference. So animal models do show that macronutrients, or sort of big parts of a diet, your protein and your fat and your carbohydrates, they sort of, what is that ratio of your diet does affect PCOS traits. I don't think we have studies in humans to necessarily prove that. We have stipulating that that's likely, but we actually don't have proof. And high fat diet probably worsen obesity in the PCOS trait. Low carb, low glycemic index, and high protein diets are probably helpful, but again, not enough sort of evidence in the studies. And Mediterranean diet may show some benefits as well. So I would say that for PCOS patients and not PCOS patients, as an internist endocrinologist, I would say to me is dietary composition, and especially I spend a lot of time on trying to move patients as much as I can toward plant-based diets, not trying to get meat completely out of their diet, but if I can get solid, healthy proteins into their diet, like fish and tofu, and not always having meat, and then introducing carbohydrates that low glycemic, more vegetables in a diet, a lot of the parameters improve. I know that cholesterol improves drastically in the plant-based diet, so I can extrapolate this for PCOS, but I don't think that PCOS in itself for PCOS in itself, I don't have any evidence to say that diets in different compositions make a difference. So a lot of unresolved questions. Just PCOS always puzzles me how much we do not know about PCOS and versus how much we know. What is the best strategy to prevent cardiovascular disease? I would say probably the same strategies you have for patients without PCOS. You need to work on weight management, and smoking an absolute no-no. It seems to drive a lot of metabolic issues and out of proportion in the patients with PCOS. And also, it would be great to understand what is sort of PCOS metabolically, because it's probably not one condition, but a multitude of conditions kind of all together. So I would like to thank you, and I hope anything I said made some sense, and I will just leave time for the next speaker.
Thank you so much, Dr. Polotsky. That was great. Our next speaker is Dr. Krausz. Dr. Krausz is a fellowship-trained Mohs micrographic and reconstructive surgeon and a board-certified dermatologist at the University of Pennsylvania. Dr. Krausz received her bachelor's degree at Yeshiva University and her medical degree at Albert Einstein College of Medicine. She completed her internship at Memorial Sloan Kettering Cancer Center and her dermatology residency at Albert Einstein, where she served as chief resident. She then completed a rigorous fellowship in Mohs micrographic surgery, cutaneous oncology, and facial plastic and reconstructive surgery at the University of Pennsylvania. She loves teaching medical students and residents and is actively involved in research focus on advancing the field of dermatologic oncology. Dr. Krausz, you have the floor.
Dr. Krausz, you're muted.
Sorry about that. Hello. Hi, my name is Aimee Krausz, and I'm an assistant professor at the University of Pennsylvania. And like we said, most of my day is spent treating patients with skin cancer, but because my practice focuses a lot on dermatologic surgery and aesthetics, I see a fair amount of patients and women specifically who come in for treatment of acne and for treatment of hair. And the first paper I wrote in dermatology as a medical student was actually about the impact of hormones on the skin. So I'm very excited to talk about this tonight. Okay. As we heard previously, in patients with PCOS, elevated androgens are one of the diagnostic criteria. Androgens are also called male hormones, and they include testosterone or dihydrotestosterone. Now, a high androgen state can either be diagnosed what we see biochemically, which means a blood test showing high testosterone levels, or just by looking at the patient, seeing what impact are the androgens having on their skin. And this will look like hormonal acne, something called hirsutism, which is hair growth in a male pattern, and female pattern hair loss. Now, just as an aside, and I think this came up in one of the questions, not all women who have adult onset acne and not all women with hirsutism have PCOS. About 35% of adults have acne, and that's normal. And the reason is because although these patients, their overall testosterone levels are normal, but the receptors in their skin are more sensitive to normal levels of testosterone. So they develop the same signs, acne, hirsutism, and hair loss, even though their blood testosterone levels are normal. In these cases, the treatment, though, will be hormonally driven and will be the same. So let's talk about hormonal acne. Hormonal acne is not your run-of-the-mill acne, and that's really important. It's usually very severe. It comes out super abruptly, and the distribution is unique. It occurs on the chin primarily and along the jawline with very cystic, painful lesions. And one way to diagnose it as a dermatologist is patients will say, I've already been on Accutane and they've already been on multiple courses of oral antibiotics, but it's just not getting better. And that resistance to therapy is usually a tip off that this is something that's different. And the reason this happens is because patients have elevated levels of testosterone. Testosterone causes elevated sebum levels, which is oil gland production in their skin, which then ruptures, there's inflammation, and then acne development. The second feature in patients with PCOS is hirsutism, which is excess terminal hairs in a male distribution. Terminal hairs are just as comparison to a vellus hair, which is a fine hair. These are thick, curly hairs that grow along the jawline in a male pattern. So mustache area, beard area, and actually on their chest and on their inner thighs. And there was also a question about this in the chat about, well, many Middle Eastern patients or Indian patients, there are certain ethnic patients that will have a thicker hair. And the difference is that it's just the thickness of the hair. It's usually thicker, coarser, and hairier, and more difficult to treat. The last of the hyperandrogenism cutaneous signs is female pattern hair loss. And paradoxically, though hyperandrogenism causes hair growth in certain areas like the beard and the chest and the inner thighs, on the scalp, it actually causes hair loss. And the pattern is very specific for hormonally driven hair loss. And it usually is more like the schematic on the top, where you have a widening of the middle part, and this can get progressively lost, so you lose most of the hair on the top of the head. Or there's another pattern in which you have what's called bitemporal hair loss on symmetrically on both sides of the temple. And the hair becomes thinner and sparser. So given that these cutaneous signs, the acne, the hair loss, and the hair growth on the face is hormonally mediated, we have to focus on treating them by blocking the hormones in the skin. And this is done in two ways. One, by reducing the amount of circulating hormones. So we want to reduce the amount of testosterone or free testosterone in the blood. And the second is by blocking the hormones action at the skin. So we've talked about a little bit before about oral contraceptives. So that's fairly an obvious thing that you could think about, where it reduces the level of testosterone in the blood, and therefore it decreases the active levels. Two other medications that I use a lot are spironolactone and finasteride. Spironolactone is actually a blood pressure medication, and it blocks the androgen receptors. So when the testosterone or any androgen tries to exert its effects on the skin, so spironolactone acts at the skin level to block it. Finasteride is the other medication that we use, and it's something called the 5-alpha reductase inhibitor. So testosterone gets converted into something called DHT, which is a lot more potent in the skin, and finasteride blocks that conversion. What's really important is that you cannot get pregnant while on these medications, because there's a concern that being on something that blocks androgens will have a negative effect on a developing male fetus. So therefore, you need to be on a birth control when you are taking these medications. So why treat acne? Well, many patients are really bothered by the cystic acne. It's painful for them. And the reason why I really try to convince people to, not convince, but I encourage people to treat it is really because of the scarring. So if you continue to get more and more acne, you will continue to develop more and more scars, and the scars are much more difficult to treat. So the main way we treat acne is by a combination of birth control pills and this medication called spironolactone. And combination therapy is really important, and also maxing out on your dose is important. Sometimes spironolactone is a blood pressure medication, so it can cause dizziness. So we usually like to start it at a low dose at about 50 milligrams, but this dose can be pushed up to 200 milligrams for patients. So if you're not seeing the effects that you should be having, that dose can be maxed out. And I also counsel patients that you really need to give it time, about 6 months, in order to see clearance and an effect of the hormonal therapy on your acne. And in combination with using the contraceptives and the spironolactone, you can continue using your topicals, your tretinoin, and your benzoyl peroxide. In terms of hirsutism, we also use the same combination therapy of oral contraceptives and spironolactone, although the data is not as good for it. And honestly, anecdotally, I don't see great effects with hormonal therapies for hair removal, and it's for hair growth. And usually what I do is I do a lot of laser hair removal, and it has to be done in conjunction with hormonal therapy. So if you just did laser hair removal, it will continue to grow back even after successfully treating it. But if you stay on the hormonal therapies, you could have a lot more of a prolonged improvement from your laser hair removal. But a lot of patients are still require some sort of maintenance, maybe once every 2 years. There are other topical medications that are kind of newer on the market for hair growth. And that's something called Vanica cream, a fluoronethine cream, which just blocks some of the proteins that are, some of the enzymes needed in the skin for hair growth. And you could use that locally twice a day on the skin. And actually something that's newer being marketed is topical spironolactone, but studies are a lot weaker with that. And like I said before, does hair regrow after laser hair removal? It will, if you do not continue medical therapy. So patients need to be combined, stay on your birth control pills while using your laser hair, and you'll often need a touch-up once every other year. Fetal parent hair loss is actually really distressing and difficult for patients. And I used to dread seeing patients with hair loss because it's something that is really hard for patients, and there wasn't a lot of good treatments for them. And the only thing we had was the tried and true minoxidil, also known as Rogaine. Minoxidil is also a blood pressure medication. And anecdotally, when patients were given minoxidil, a random side effect that was noticed was that patients developed hair, and then it started to become marketed for patients who had hair loss. And this is used topically. You basically rub it into your scalp twice a day. The one for women is marketed as a 2.5% solution. So it's the lower dose. For men, it's 5%. And the reason is because it's not a targeted therapy. So patients who use it on their scalp could sometimes develop a peach fuzz on their skin. So if patients are really sensitive, then they would stick with the 2.5% if you're a female. But many women don't develop this peach fuzz, and you'll see a much better effect with the 5%. So I always tell patients, just get the 5% and actually don't pay for the brand name. Rogaine is about twice as expensive. You can go to Costco and get yourself topical minoxidil and use it twice a day and really see good improvement. The key for this is staying on it. And what minoxidil does is it shifts your hair. There's cycles to the hair, something called an anagen phase and a telogen phase. A telogen phase is a shedding phase. So minoxidil shifts your hair towards anagen. And if you stop using it, it will shift back and you will shed. So patients have to basically stay on this for life, but it's not something that has any systemic effects, and it's something that's easy to use. Nowadays, though, for many women, we use oral minoxidil. It is also a blood pressure medication and it can cause a lot of hypotension. So we start at a low dose. And other patients have really good effects with oral finasteride, which is that medication I was talking to you about before, which blocks the conversion of testosterone to DHT in the skin. But with these, with both oral finasteride and spironolactone, patients cannot get pregnant. Some newer therapies that are really exciting and that I do in the office is something called platelet-rich plasma. This is something considered a cosmetic procedure. So this is kind of expensive and patients have to be willing to pay for it and willing to also stick with it. It's basically one treatment a month for 6 times. But patients really are doing well with it, but not everybody responds well. So I usually tell patients, if you don't respond after your second treatment, stop it because you're just not the type that's going to respond to it. And what it is you draw the patient's blood and you spin it down so that you have, your red blood cells at the bottom of the tube, but you have the platelets, which are a component of the blood that has a lot of growth nutrients and growth factors. And you inject that into the scalp, and many, many patients see a really good improvement with that. A word on, so a lot of patients ask me about something called biotin, which was really marketed for hair and nail growth. And it's a B vitamin that's found in many foods that we eat, nuts, vegetables, fish, and meat. And I always tell patients not to take this medication because if you're on a normal, healthy diet, getting excess of a certain vitamin is not going to give you better effects. You'll get enough of the biotin in your diet to have good hair and nail growth. And what happened was that the biotin in the blood actually skewed some of the lab tests. So there occurred a certain number of reported cases of women who were misdiagnosed and they missed a diagnosis of a heart attack because the biotin in their blood bound to troponin. Troponin is the protein that's measured in your blood when someone has muscle injury in their heart. And these troponin levels were falsely low, and patients were not diagnosed with a heart attack because they were taking their biotin. So now many dermatologists counsel their patients not to take it because of the side effects for other lab tests, including thyroid as well as troponin. So if you're eating a normal, healthy diet, you don't need anything else. Well, thank you. And if you have any other questions, feel free to reach out to me. Thanks.
Okay, thank you so much, Dr. Krausz, and thank you to all our speakers. We're about to start the Q&A section of the event, so please keep in mind that we cannot give specific medical advice. All right, we're gonna start with the first question. The first question is, how does having hypothyroid affect chances of having PCOS?
I don't know if Dr. Polotsky wants to take that, but I'll take at least initial stab at that. Basically, the diagnosis of PCOS, you have to exclude hypothyroidism. So the hypothyroidism has to be fully treated before you can tell somebody that they have PCOS, because hypothyroidism in and of itself can cause irregular cycles that are completely independent of whether somebody has PCOS. So, but hypothyroidism is a relatively common endocrine disorder that we see in women, particularly, women in their 30s and 40s. So reproductive aged women, and it has all sorts of implications for reproduction. But the two are, while there are lots of overlap, there's lots of people who have both, they aren't necessarily related, and there needs to be PCOS symptoms even after you've treated the thyroid.
Okay, Dr. Polotsky, would you like to add anything? Or?
I'm good. We can go to the next question.
Sure. So does PCOS cause miscarriage?
Now, I answered that I typed a little bit in the chat, but I'll address it. We don't have a lot of data. And this is one of those things, as Dr. Polotsky brought up, that there's a lot still that we don't know related to PCOS. But I will say this, the biggest factor associated with miscarriage is going to be age. Miscarriage rates go up as women get older. That's just standard. There are some studies to suggest that maybe women with PCOS have higher rates of miscarriage than other women their age, but there hasn't been really good definitive studies. And there's lots of other factors that may also be working here. So thyroid, for example, hypothyroidism is a cause of miscarriage. elevated glucose, poorly controlled diabetes, poorly controlled other aspects that run along with PCOS but aren't necessarily part of the diagnosis, can also cause miscarriage. So there's a lot of there are a lot of factors here, and it's hard to say if PCOS by itself as an independent risk factor could lead to miscarriage. But the good news is that, like we said, most women with PCOS are going to go on to have families, are going to go on to get pregnant. Many can conceive spontaneously on their own and have live births. So overall, the prognosis of getting pregnant and having a family, the chances of meeting your goals is going to be high, even if you have PCOS.
Okay. What would you suggest for someone who has acne, who is pregnant or is trying to conceive?
So there's a little bit of a debate about whether patients need to stop their spironolactone or the finasteride if they're trying to get pregnant, because many patients will, unfortunately, if they take a while to get pregnant, then their acne is going to flare. Usually I do recommend my patients stop it. However, actually, I just got texted by a friend about a patient who had PCOS, who had been on spironolactone, and she just found out that she's pregnant and she's 4 weeks pregnant. What does she have to do? And there's no data to suggest that there's going to be any damage to the fetus. And especially organogenesis happens between 6 to 10 weeks of pregnancy. So even if you were on the spironolactone and you just stop it, then you should be okay. As well as the finasteride has a super short half-life. It's about 6 hours. So in about 2 days or so, that should be out of your system. That being said, when you are pregnant, you obviously cannot be on these medications. And then you really just, a lot of patients who are pregnant, they can't be on their Accutane either. So it's not unique to PCOS, and they could use things like benzoyl peroxide, clindamycin, azelaic acid. But yeah, there's not great treatments when you're pregnant, unfortunately.
Okay. If someone isn't sexually active yet, is it better for them to see and talk to someone about their possible PCOS symptoms? And if so, should it be an OBGYN or an endocrinologist?
So I would say just because you're not sexually active does not mean you can't see an OBGYN. And if you're having cycle irregularity and that's your main symptom that you want to address, then an OBGYN is the perfect person to talk to, and you don't need to be sexually active to see them. If the major bothersome symptoms are more metabolic, things like weight, or hair, or all these other sort of non-reproductive, non-cycle related aspects, then an endocrinologist or a dermatologist may be the best person to speak to. But you don't have to be fearful of the gynecologist because you're not sexually active, especially if cycle irregularity is kind of the major thing you need to address.
Okay. Someone asked, what is the name of the injection therapy used for hair? Does it have a history of does a history of ITP affect the therapy?
So it's called platelet-rich plasma. And what it does is basically you go into the office, they draw your own blood and then spin it down. And you have the red blood cells that settle at the bottom. And then you have your platelet-rich plasma, which is your the growth factors at the top of the tube that then gets extracted and injected into the scalp. And you need about 4 to 6 treatments in order to see an effect, but many patients do really well. I don't think, that's a really good question about the ITP. And if you email me separately, I could look into that, because I don't think that should really impact it. I think that you should have enough growth factors in the serum to have a good effect, but that's a good question, and I could look into that for you.
Okay. If someone is a carrier for CAH, is it possible they can be misdiagnosed with PCOS?
All right, I'll tackle that one. So there's a difference between being a carrier for CAH, which again stands for congenital adrenal hyperplasia, and actually having congenital adrenal hyperplasia. So congenital adrenal hyperplasia is a genetic disorder. The genetics of it are a little bit more complex than the typical sort of recessive mutation that people generally think of, but it is more or less a recessive mutation where you need 2 copies of a mutated gene in order to have congenital adrenal hyperplasia. So being a carrier for congenital adrenal hyperplasia means you have 1 mutated copy of the gene and 1 normal. generally. Remember, it's a little bit more complicated, but I'm simplifying. So if you have a normal copy of the gene typically associated with congenital adrenal hyperplasia, which is the 21-hydroxylase enzyme, then you're healthy and you don't have any symptoms of the congenital adrenal hyperplasia. And if you're seeing menstrual irregularities and hair growth and some of these other symptoms we've discussed, it very well could be PCOS. Part of the traditional PCOS workup is going to include ruling out congenital adrenal hyperplasia. It's one of the first sets of labs when we talk about ordering PCOS labs on women. What PCOS labs actually mean is we're looking at labs to exclude other factors, and congenital adrenal hyperplasia is a big one, especially in in Ashkenazi women, because the carrier rate for CAH is actually quite high. So you mentioned, I think if we have 180 women on this chat, there's going to be a fair number who are going to be carriers of CAH. People have estimated that as being as high as 1 in 6 in the Ashkenazi Jewish population. So that can be, so being a carrier does not mean you have CAH, but if someone did have CAH, that could mimic PCOS.
Okay, and the last question is, what is the best diet for someone with PCOS, and are there supplements that could be used to mitigate the symptoms of PCOS?
I'll take this one, and then if you guys want to add to that as well. So I would say the best diet is the diet that works for you. So I have certain preferences for diets, that are also more health oriented, but it depends if you are, 18 or 17, or you are, get closer to 40s, when I'm getting more concerned on having people on a high protein animal fat diet versus, healthier protein diets. So I would say that I suggest people to start with the weight management physicians early, if needed. Not every endocrinologist does weight management. If your BMI is an obese, or super obese range, which is BMI usually, even if you're in overweight, I would suggest if high overweight, which is BMI of 27 and above, it may help to be in a more formal dietary program, because there's a lot of support that needed, because we all know what needs to be done, but it's very actually hard to do what needs to be done and sustain it. So I personally go for more healthier diet in PCOS because of the metabolic issues than regular patients. So I try to do, again, as I mentioned in my talk, closer to plant-based diet, which means that pick your protein from some fish or chicken, not necessarily heavy, I would say heavy Shabbos diet with a lot of cholent and other things. That's not the diet I would say I would advise for everyday diet. And whatever works for you. Exercise is also extremely crucial in combination with the diet. There are also weight loss medications that could be used, and you can use them at small doses. You not advised to get pregnant on the weight loss medications, so you just have to be careful. But I think there's a combination of things that you could use between the medications and the healthier diet to be able to lose weight. Again, it's the weight that you're going to lose is going to drive PCOS more than anything else.
Okay, so thank you everyone for joining JOMA's webinar on PCOS. Thank you to Dr. Maslow, Dr. Polotsky, and Dr. Krausz for educating us on such important topics. We also want to give a huge thank you to Extend Fertility for sponsoring this webinar. And of course, thank you to the Women's Health Committee members, Sahar, Denise, Miriam, Jackie, and Nicole for organizing this event. Lastly, I just want to remind you that JOMA is a nonprofit organization and a free community resource. And if you'd like to donate, there's a link in the chat box, and you can also find a place to donate on our website. Thank you for joining, everybody.